And we must use 10% neutral preferred formalin in this because the processing of these tissues damages the DNA. So if you use 10% neutral preferred formalin, the fragmentation is minimized. Dual acetate based buffer and not salt based buffer, which is usually a practice in our hospitals, has to be recommended, and that the minimum interference with the PCRs is seen in these in samples which are processed like this. The fixation time, the more that a tissue spends a time in formalin, the more cross-linking happens. So that has to be minimized, and around 6 hours is recommended for small biopsies. And there are certain biopsies where so in certain biopsies, it must be emphasized that if you're not needing that IHC or that panel of IHC, you may not do all the panel of IHC, only the minimal IHC can be done. So we have been receiving samples from outstation units and our command hospital here. So this is the spectrum of blocks that we've received. The good are the ones where it is easy to extract the DNA and the RNA. The bad are the ones where there is just an eosin speck and we have to really struggle to get 200 nanograms of DNA that is required to run these panels. And the ugly ones are, of course, there is no real tissue that is left for processing and we have to reject those samples. Little advice to my histopathology colleagues: when you report a tissue or report a cancer, please mention the tumor percentage in that slide or in that block. Please send the block with the highest tumor content for us to take it forward to NGS. And please report if there are areas of necrosis and hemorrhage, because both of these interfere with NGS testing. So when you sending a block for molecular testing, please mention the block with maximum tumor content, send the HP report, and avoid areas of necrosis. So once you send the sample, the requisition should include all the following details. HP report is absolutely necessary and the tumor percentage would be good. At reception, if you send a slide, then we can actually verify the tumor content and choose the right areas and avoid the necrosis. So this is in brief the NGS workflow that happens. Once you send a sample to us, we do a process of sample preparation, sequencing. Once the sequencing data comes to us, there is a long process of data analysis, variant annotation, functional classification, and clinical actionability mapping that happens. So this does take a lot of time, and that is why the turnaround time is around 3 to 4 weeks for most NGS panels. So for my oncology colleagues and my pathology colleagues, if you want to go detail in this, there is recommended reading, certain guidelines for Association of Molecular Pathology, which are available. For interpretation of our reports, it is recommended to go through the NCCN guidelines, which tell you which mutation and is targetable by which drug. There are ESMO guidelines which also help in interpreting these reports. There is a lot of content that I'll be just showing. And the ESMO guidelines, that is the European Society of Medical Oncology, they also tell how to prepare a report and what should be the recommended content of the report. So this is the report content as per the ESMO guidelines. I'll just show you what, and we are following this exact pattern of our reporting. Once we report a variant, we classify this variant based on its sensitivity to FDA approved drugs. So if there is an FDA approved drug, then we classify it into tier 1. If there are certain research areas and out of recommended scope, then tier 2. Tier 3 are variants of uncertain significance, and tier 4 are benign or likely benign variants. We try and report almost all the variants that we see with some therapeutic impact. So this is one of our reports here, which is a comprehensive genomic profile TrueSight Oncology 500 gene panel. So as per the ESMO guidelines, there is an interpretative summary that is given that tells the summary of all the mutations that we have found. Then we classify these variants based on their druggability or targetability into 1A or 1B. Now, in this case, like we have got KRAS and TP53 mutations. Then there are certain additional findings such as tumor mutational burden and microsatellite instability. And then there are detailed descriptions of each of these variants. Like if there is high TMB, then what does that mean? If it is oncogenic, what is the actionability? Which are the drugs that this mutation is sensitive to? So this is the number of samples that we've received in the last 1.5 months at our lab, around 43 in total, and we've been able to report out 16 of them. One of the reasons that the turnaround time is not being met presently is because different tumor sets are coming at different timelines, and the first sample that came essentially we can minimum samples, 8 samples we can put in one run. So to accumulate those 8 samples, it is taking some time. But if once the sample load increases, I think the turnaround time will be met. So this is the summary of the presentation. Precision Oncology's NGS is the standard of care today. And we briefly discussed the guidelines to share the samples and send the samples to us. Thank you.
Thank you, Colonel Anurod. Now I open the house for a few questions if there are any.
Sound like a stupid question. Don't take it otherwise. When you're looking at such a small fragment like a DNA fragment, why do you want more tissue? Like you kept harping on more and more tissue.
Yes, sir. Actually, the good, bad, ugly, if we saw, sir, we require at least 10 micrograms of tissue to get 200 nanograms of DNA. 200 nanograms of the DNA is what is required for putting any of these runs. Now, once the tissue undergoes these steps of formalin fixation and paraffin embedding, the DNA gets fragmented into very, very small fragments. So to out of that, to take out that fragment, which is a minimum 200 base pair length, the minimum base pair length is 200. So the useful DNA actually comes out very, very less, and that is why more and more tissue is required.
So as the previous presentation showed about forensic NGS and forensic. So are we also doing mitochondrial DNA and all?
So mitochondrial DNA
for maternal lineage,
So we have a mitochondrial DNA panel with us. It is usually done for rare genetic disorders, which are inherited through mitochondrial genomes. We are not offering it on the somatic mode. DNA fingerprinting, the feasibility is there in our lab, but there are a lot of legal aspects that need to be taken care before we can get into that.
And if we compare our NGS, like we're doing, you said 330?
So 523 and
in comprehensive genomics.
Yeah, sir.
And in the previous one you had shown?
The first one is a 60 gene and 20.
60 gene.
Yes, sir.
So like if we compare it with Foundation 1, so are we thinking, can we go ahead and make it even better? I mean,
I'm sorry,
comparing it with the Foundation where they're doing almost about 500 different genes which you're testing.
So the cost of
will go up.
Yes, sir. The cost, the more genes, the more cost. Each flow cell around 12 lakh rupees. If we put less than the more data per sample, the less number of samples will go into each flow cell, and much of those data is actually not useful as of today to the patient. It can be useful in the research mode. It will help us generate more data. But from therapeutic point of view, we maybe 120 gene mutations are which are targetable as of today.
So, sorry for cutting it again. So for like the lung cancer panel, instead of doing a whole genomic sequencing or something, we know that these are the actionable mutations. So we just need to do AL, CRAS, REF, MET skipping, all the standard tests because these are all actionable. So in lung, we actually can limit or panel.
So, yes, sir, that's what I explained, sir. So that 60 gene panel, I mean, you will send me maybe 2 lung cancers in a month or 3 lung cancers in a month. But the 60 gene panel will help me collect all the oncology samples that I get in one run, and I can put it so that your turnaround time for lung cancer and breast cancer and ovarian, everything can be pooled into one. So the 60 gene panel. For lung cancer, only maybe 20 gene would be enough, sir.
So, thank you, Colonel Anurod. Now I request Commandant Command Hospital Southern Command for his comments.
Thank you for the wonderful presentations. All 4 presentations were totally different. And I'm sure we are all now enlightened about all the presentations. All were well presented, well discussed, and in the case of the orthopedics, very well managed. That's all.
Thank you, sir. So now I request our commandant for his comments, sir.
Echo what the commandant of Command Hospital has said. I think all 4 of them were thought-provoking, and of course, I go back with a lot of things I have gained from here, and I'll possibly go back and read a few things on my own. The first thing is regarding the mathematical model. Though I didn't follow to all that great extent, but what I could take from it is that possibly he's just brought out a mathematical model based on whatever available literature is there. And possibly it will be validated once we have further possibly data from either you have a high intensity workout or a strong intensity workout, and possibly come up with some sort of conclusion as to which are those ones where the heart rate is going to behave in what particular manner. Yes, definitely I'll go back and read about it, and possibly it does have some sort of implication on our sports medicine people and our own why people have certain cardiac deaths and things like that. The second one was on the orthopedic case. Yeah, another interesting thing. My only thing about the orthopedic thing is why does it happen and why only it happens to some subset of patients? Maybe I'll go back and read, because as he rightly said, this is not a class on the why this abnormal ossification happens. The third one regarding the forensic identification of the unfortunate thing that happened. I don't know what would have happened if there was the same accident would have happened in a crowded area where there was possibly other people also involved. I do not know how the outcomes would have been, and what can we do further. That also is, I think, lot of legal issues are there. Maybe it's something which we can think about. And finally, about the next generation sequencing. The main aim of why he presented was to spread awareness that such a thing is there with us, and please subscribe to it. And of course the onco people and all are already doing it. We used to send samples outside. Now I think we should send more samples there. How to send samples, that also is a gray area. People do not know. So he's explained it well. My own sort of experience, one of my relatives had a CA lung about 6-7 years back, and of course when the private labs, possibly they get all the CA lungs together and they run the thing, so they do not do the complete 60 panel or whatever. They must be doing just about 20 which are required for lung. And fortunately the ALK mutation was positive and treated with Jeftinib, and now the patient is almost disease free. So I think all four is well presented and thought-provoking and well done.
Thank you, sir. So with this, I conclude this session on monthly clinical meet, and thank you everyone for the patient hearing. Jai Hind.